Hello and welcome again to the Emergency Medicine Clinics podcast. I'm Patrick Manley, the manager of the Clinics program. Emergency Medicine Clinics is a quarterly publication consisting of review articles centered on a central topic. Today we'll be discussing the recent issue on neurologic emergencies. Joining us now is one of the guest editors of this issue, Dr. Jonathan Edlow from Harvard Medical School. The first article I'd like to look at is a new approach to the diagnosis of acute dizziness in adult patients, which you wrote. It seems that defining dizzy with what patients are experiencing is a challenge to the ER docs. Can you take us through how you address that?
Yeah, the traditional way that all of us have been taught to take care of dizziness is to ask the question to the patient, what do you mean dizzy? And then the patient might say that they have vertigo, they have spinning, they feel like they're lightheaded, they might faint. And that organizational scheme is based on literature that was published in 1972, quite some time ago. And the literature is really extremely flawed and really not based on modern methodologic standards. In addition to that, over the last decade, there has been a lot of new literature that really undercuts the validity of that "what do you mean dizzy" construct. And in fact, it's kind of like if you were to take a chest pain patient and say to the patient, what do you mean chest pain? And if they use the word sharp chest pain or pressure chest pain or tearing chest pain, you isolate your differential diagnosis to a given set of possibilities. The reality is that we take a history in a patient with chest pain or headache or abdominal pain or back pain in terms of the timing of the symptoms and the triggers of the symptoms. Did it begin gradually? Did it begin abruptly? Is it triggered by motion? Is it triggered for chest pain with exercise? And it's really the timing and triggers. And the first part of this article really is about applying this same thing, the way you take a history in any other patient, to patients with dizziness. And that's how the history should be taken. It's the timing and the triggers and the epidemiologic context, the age of the patient, vascular risk factors, all the usual stuff that you do routinely should be done in patients with dizziness.
Can you take us through triggered episodic vestibular syndrome?
Yeah, so it's, a lot of words. It makes it sound like a very complicated thing, but, just as patients are very imprecise about the word that they use and what that word means, they're pretty good about the timing and the triggers of dizziness. So a triggered episodic vestibular syndrome means that someone who gets brief episodes of dizziness that are triggered by something. And the something is almost always moving of the head, standing up from the seated or lying down position, and the differential diagnosis of that is usually BPPV, benign paroxysmal positional vertigo, or orthostatic hypotension. And BPPV is pretty common. I only work now about 8 clinical shifts per month, and I'll see at least 5 or 6 cases personally each year. So it's a pretty common diagnosis. And I always liken it to, it's kind of like the nursemaid's elbow of neurology. That is to say, it's a diagnosis that you can suspect from the history, you can prove and then fix with bedside maneuvers. And as such, it's a really satisfying diagnosis to make, both for you and for the patient, because you can fix it right then and there with an Epley maneuver, and the patient feels better very quickly, as opposed to having them wait for 2 or 3 weeks for a follow-up with a neurologist or an ENT person. So BPPV is a really important diagnosis because it's common, it's easy to diagnose at the bedside, and it's easy to treat at the bedside. And the treatment should not be Valium or Meclizine and things like that. It should be a curative bedside maneuver, which is pretty effective.
Let's look at the section on spontaneous episodic vestibular syndrome.
Yeah, it's tougher to nail down because this one is pure history. So if a patient came in and has had dizziness that began, 6 hours ago, and they were still dizzy, then that would be an acute vestibular syndrome. they would still be dizzy, and then the physical exam is extremely helpful in sorting out, is this vestibular neuritis or is this a posterior circulation stroke? But with the spontaneous episodic vestibular syndrome, it's no longer present when you see the patient, and by definition, it's spontaneous. It's not triggerable, so you can't trigger it by doing a Dix-Hallpike, for example, like with the prior group of patients. So here it's pure history. And, most older or even middle-aged emergency physicians and physicians of any type have been taught that TIA, that isolated vertigo, isolated dizziness is never a TIA. And in fact, that's just wrong. It's been shown in numerous studies at this point, probably the best one published in 2013 of 1,150 or so stroke patients. And it's clear that a certain non-trivial but small percentage of patients will have a TIA that is isolated dizziness, often vertigo, but not always, that might last for 10 or 15 minutes, and when you see them, they're completely normal. So here in a spontaneous episodic vestibular syndrome, the major differential diagnosis is TIA, which is an obvious, important, and dangerous diagnosis, versus vestibular migraine, which is a migraine variant, which is an extremely common and benign diagnosis.
Any final thoughts on this one?
Yeah, I think that, there's a algorithm that I've included in it. I have to say that, dizziness is one of those chief complaints that if you were working double coverage and you and your partner got up to the chart rack at the same time, and there's a chest pain patient and a dizzy patient, 10 times out of 10, physicians are going to go for the chest pain patient. Using this algorithm and thinking about it, and I've been using this algorithm for probably 7 or 8 years now, dizziness can actually be a clean, clear, algorithmic type of symptom, and the approach to it is actually a lot more fun for me than it used to be. So I would encourage people to think about dizziness, to read this article, think about this different approach, and you'll actually make a more confident, specific diagnosis more frequently using fewer resources and fewer neurology consults and fewer CTs, which are basically worthless. So you'll do a better job and you'll have more fun, and maybe the next time you find yourself at the chart rack with your colleague, you'll choose the dizzy patient and not the chest pain one.
Next up, I'd like to look at acute non-traumatic back pain, risk stratification, emergency department management, and review of serious pathologies by Dr. Singleton and yourself. Can you take us through some of the key takeaways from this article?
Yeah, I think that the key takeaway here is that, like dizziness, it's a rare shift that goes by where you don't have a patient, at least one patient, with back pain. And back pain is caused by benign problems probably 95 times out of 100. So most of the patients we see with back pain have fairly trivial problems. They don't need any blood tests. They don't need any imaging. They don't need any consultation. But they do need a careful history and physical exam so that you can tease out those patients who don't need any further management or testing, and those patients that do. So the first part of the article really gets into red flags. So things by history and things by physical exam that place the patient at higher risk for having a serious cause that is causing impairment to neurological structures, either of the spinal cord or the spinal nerves in the cauda equina. So it's basically, figuring out who's got red flags and then managing the patients without red flags differently from the ones that do have it.
Let's look at the section on management of simple back pain.
Well, the management of simple back pain is relatively simple, actually. The types of treatments that help these patients are ibuprofen and other nonsteroidal anti-inflammatory medications, Tylenol, early resumption of normal activity. Most of the guidelines, and there are no emergency medicine guidelines, but the American College of Physicians actually just came out with an updated guideline this month that is February of 2017. They really focus on these relatively simple interventions, avoiding opioids, avoiding muscle relaxation. In my own practice, I do prescribe opioids if I think a patient has a lot of pain, but I prescribe a very limited amount. I'll give them, 15 or 18 or 20 maximum to be used for the first 2 to 3 days and to be stopped after the third day. Opioid addiction, as everybody in our specialty knows, is a major issue. So on the one hand, we need to be careful about treating chronic pain with opioids. On the other hand, if someone has major acute pain, I think that giving them for a couple of days makes sense. The data on muscle relaxants are pretty plus minus. I think most people use either a benzodiazepine or cyclobenzaprine, Flexeril. I think those are okay to use, but again, for a short period of time. There is a fair amount of data that shows the sooner patients get back to normal activities, the faster they get better. And then the other thing in these patients with minor back pain or simple back pain that don't have risk factors for serious diseases, it's important to give careful follow-up instructions about what to expect, because there will be some patients that have a central disc protrusion, for example, or a spinal epidural abscess, or epidural hematoma, or epidural cancer metastasis, who won't have red flags. The abscess without a fever, or the epidural tumor without a history of cancer. So follow-up instructions are also very careful because the red flags are not perfect.
The MRI checklist is a nice component of this article. Can you take us through the importance of these procedures?
Yeah, so the MRI checklist came from experience in our department. We had a number of cases of spinal cord or cauda equina syndromes where we had a delay in diagnosis. And when we looked at the reasons for the delay in diagnosis, a lot of times it was a delay in getting the MRI. And the reason that we had delays in getting the MRI were in large part preventable. So simple things like making certain that the patient can actually lie down for the duration of the study. These studies can be, 45 minutes, and if a patient has a lot of pain, they might not be able to lie still. So just paying attention to, is the patient appropriately analgesed? The MRI is not a fun place to be. I personally had MRIs, and it's not a fun place to lie down in this tube with very loud noises. So is their anxiety appropriately managed? Making sure that you image the right part of the spine. So discussing with the radiologist, do they need just the lumbar spine? Do they need the thoracic spine? For patients where the question is cancer or abscess, most neuroradiologists and neurologists recommend imaging the entire spine because there can be skip spots, and that can be important in terms of surgical planning or in terms of planning radiation therapy ports. If you're just looking for, if someone has a focal finding like a spinal cord level, a sensory level, then you can be a little bit more focused. Or if you're worried about just the cauda equina, you can focus on the lumbosacral spine. So having a discussion so that the patient doesn't have to go down to the MRI machine and then come back again. Making sure that there's no contraindication. Even make simple things like making sure that the MRI checklist has been filled out, that the nursing staff knows that it needs to get filled out, that they know where to fax it. There's all these little things that we found we were burning a lot of time to get the MRI. And then finally, occasionally one needs to intubate a patient in order to get them to lie flat, to safely analgese them. And a couple times a year in our department, we will do an elective intubation in order to get an emergency MRI. And that's just necessary some of the time.
Any final thoughts?
Yeah, I think one other thing is when you get a negative MRI and yet the patient has a large amount of concern, or you have a large amount of concern about the patient, or the patient has hard physical findings, you need to kind of think through that. I personally call the radiologist and go through the MRI with them, because an abnormality on physical examination will always trump a normal MRI. There's something that's going on causing that abnormal physical finding. So if you have a negative MRI in that setting, you really need to question, is that really a negative MRI? Is the scan technically adequate? Have the correct levels been imaged? Was contrast used if it was necessary? And you really need to think about what the next steps should be. And the important thing, again, is an abnormal physical finding, a hard physical finding, trumps a normal imaging study.
Lastly, we'd like to discuss diagnosis of acute neurologic emergencies in pregnant and postpartum women by Doctors Andrea Edlow, Brian Edlow, and yourself. Can you give us some background on this topic and how it's come to be managed?
Yeah, I will say that the first thing is that although we all have the last name, and it's an uncommon last name, remarkably, I am not related to them. Brian Edlow is a stroke neurologist and neurocritical care physician, and his wife, Andrea, is a maternal fetal medicine OB doctor. So it's crazy, but we're not related. So that's the first thing. The second thing is that, this is a really important group of patients because these are patients that are young, healthy women for the most part. They're either about to have a baby or they've just had a baby. So the social context of being wrong in this setting is huge. In addition to that, a lot of the diagnoses that lead to neurologic abnormalities in this group of patients are uncommon things. Things like reversible cerebral vasoconstriction syndrome, PRES, or posterior reversible encephalopathy syndrome, cerebral venous sinus thromboses. These are common diagnoses in this group of patients, but in our overall practice as emergency physicians, they're pretty uncommon things. And then finally, the go-to test that most emergency physicians use with patients with neurological problems is the CT scan. And the CT scan is negative in the large majority of these problems. So that's the context. It's a high risk issue in a young, healthy patient that can have some uncommon diagnoses, and our go-to imaging test is usually falsely negative.
Let's go over the acute neurologic symptoms and deficits.
I kind of listed some of the different types of pathologies. Another thing that one should mention in this group of patients is that stroke, although it is still fairly uncommon, it's much more common than in non-pregnant women of the same age. So ischemic stroke is something that we need to think about in these patients. And occasionally the issue will come up with a hyperacute stroke in a patient who would otherwise get thrombolysis with TPA. And there are case reports and there are opinions that pregnant women who have an acute ischemic stroke, if otherwise they meet criteria, should be treated with TPA. This is a high-stakes decision, and I would certainly involve neurology in a case like this, or maternal fetal medicine in a case like this. I don't think it's reasonable for an emergency physician to make that decision on their own, but know that TPA is not contraindicated in all of these patients. So I guess the first step is doing a careful exam to document what the deficit is. The second is to recognize that the differential diagnosis in these patients is different than the differential diagnosis in non-pregnant patients, or at least the frequency of some of these oddball diagnoses is much increased. And that there's overlap between things like venous sinus thrombosis and eclampsia and PRES. And the other thing is that, our go-to diagnosis in these patients is eclampsia. And the reality is that, and we'll talk about this when we talk about seizures, eclampsia is not always the correct diagnosis.
How common are seizures?
Well, again, seizures, in and of themselves in a young, healthy woman are relatively uncommon. But seizures in pregnant women lead to a different way of thinking about it. Now, it could be that this is a patient who had seizures prior to the pregnancy and is just having another one of their typical seizures. It could be that this is a patient that has a new seizure disorder that's unrelated to the pregnancy. So they've developed a brain tumor that they were, growing for the last year, and they happen to have their first seizure during pregnancy. But the types of seizure disorders during pregnancy that are pregnancy-related really have to do with all those diagnoses that we just listed. So PRES, eclampsia, venous sinus thrombosis, ischemic or hemorrhagic stroke, occasionally reversible cerebral vasoconstriction syndrome. So it's not common, but when it happens, again, the go-to diagnosis here is eclampsia, and we are diagnosing postpartum eclampsia more and more frequently. But I think that unless it's absolutely clear to an experienced, OB or neurology doctor that this is isolated eclampsia, that you do need to think about getting an MRI in these patients to look for these other diagnoses that we've talked about, because they're often treated differently than eclampsia.
Any thoughts on the issue as a whole that you would like to share?
Yeah, I think that, the reality is that one needs to have a much lower threshold for MRI because most of these patients need an MRI to make a diagnosis. And then the other side of that is that the majority of these patients are postpartum, and even if they're in their last month or so of pregnancy, which was when many of these neurologic events happen, it's okay to do a CT scan. You shouldn't not do it because of radiation concerns, but it is important to consider getting the CT. If you make a diagnosis, great. If you don't make a diagnosis, you need to think about going to MRI.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today focusing on neurologic emergencies, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. A CME program is also available. For more information, visit info.theclinics.com. Be sure to follow us on Twitter @eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes and the Google Play Store. Recent issues of Emergency Medicine Clinics have focused on geriatric emergencies, psychologic and behavioral emergencies, and severe sepsis care in the emergency department. Thank you, and we'll see you next time.